on respiratory system. The presenter is Dr. Neelima T, who's a junior resident in family medicine in VPS Lakeshore Hospital, Kochi. And to moderate the session with us, we have Dr. Mujib Rahman. First of all, thank you so much, sir, for agreeing to moderate the session in such a short notice. Dr. Mujib Rahman is a consultant in Department of Pulmonology at VPS Lakeshore Hospital, Kochi. Sir has done his MBBS from Government Medical College, Thrissur. MD Respiratory Medicine was done from Institute of Medical Science, BHU, Varanasi, and DM in Pulmonary Critical Care and Sleep Medicine from AIIMS, Bhubaneswar. Dr. Mujib is also a reviewer at BMG International Journal. Over to you, sir. Sir, please unmute yourself, sir.
Thank you for the kind introduction. Very good evening to all of you. It's my great pleasure to join with all of you young family medicine aspirants and the consultants or the practicing physicians across the country. And today we have one interesting case. Case will be presented by Dr. Neelima, our resident. Without much delay, we'll proceed. Neelima, over to you. Our plan of discussion will be, we'll go through the case, in between we'll stop and we'll discuss the relevant points according to the situation and the scenario. And discussion will be more focused on symptomatology, differential diagnosis, how to approach a clinical diagnosis, and very brief about management. Okay.
Hello, am I audible?
Yes, Neelima, you are audible.
Good evening, all. Today, I am presenting a case of a 16-year-old boy pursuing his higher secondary education computer science, residing at Udayamperur, Kochi. He got admitted in our hospital on 21st October 2022, and I have examined him on 3rd November 2022. His chief complaints are right-sided chest pain, increased cough with expectoration, and fever for a duration of 2 weeks. Coming to the history of present illness, the 16-year-old boy presented with complaints of catching type of chest pain on right lower chest, which was insidious in onset. This chest pain increased on coughing and deep breathing, and no relieving factors noted. The severity of the chest pain aggravated over the past 2 weeks. Along with the chest pain, he had cough with expectoration. Of copious amount of greenish, foul-smelling sputum around 1 cup. It was more on lying flat and during midday time. He has also noticed streak of blood in sputum and he has foul-smelling breath. Along with the cough with expectoration, he had fever, which was low grade, sometimes during the morning hours and sometimes during evening hours. The fever subsided on taking paracetamol. He took a course of antibiotic consulting in a local clinic, but the symptoms worsened. Hence, he came to our hospital. There was no history of dyspnea, wheeze, nasal discharge, headache, orthopnea, paroxysmal nocturnal dyspnea, or pedal edema. So, shall I proceed?
Okay. So, here we have a case of a young patient, 16-year-old boy. He presented with cough, purulent sputum, and occasional blood-stained sputum, and fever. So these were the history, and it was all aggravated for last 2 weeks. So looking at the history itself, our first impression is we should reach, first we have to reach which system is affected, and after that we have to reach in which system. Like if it is respiratory system, we should reach with the history. What are the organs like airway disease, or is a parenchymal disease? Is it a pleural disease, or is a vascular problem, or a musculoskeletal problem? So from your history, Dr. Neelima, there is fever, chest pain, and purulent sputum with occasional blood stain. So what is your impression? Which system is affected in your history, and what are the area of system you are focusing?
From the history of cough with expectoration and bloodstained sputum, it's the respiratory system that is involved.
Yeah.
With the
Okay. Then within the respiratory system, we have airway disease, we have parenchymal disease, or we have pleural disease, or vascular disease, or maybe a combination of all these things. So, out of your history of fever with purulent sputum and hemoptysis, where will be the pathology? Where will be you are looking in looking at the history?
combined involvement of airway and parenchyma.
Airway and parenchyma. Okay. But you are also telling there is a pain of the chest, right? Say, which is increasing with the inspiration and the deep breathing and coughing also. So, and it is not relieving. There is no relieving factor according to your history. But I feel there is a pleuritic kind of chest pain, and pleura may also involved.
Okay.
What do you think?
Yes, sir. There could be associated inflammation of the pleura that is causing
Pleura
the
also.
pleuritic chest pain.
Okay. So the important airway disease we will be looking is in young adults. What are the airway disease we will be going or we will be commonly seeing, or what are the airway disease we should look at?
Asthma,
Yeah.
bronchitis,
Yes.
then bronchiectasis.
Okay. So common is this asthma or bronchitis or bronchiectasis. COPD is very unlike age group. Usually we'll call COPD only after the age of 40. But there are now the recent guideline is dealing with early COPD, but still it's not a diagnosis in young patients. So parenchymal disorder with your symptoms like fever, cough, purulent sputum, what are the parenchymal problems which can have?
So it could be pneumonia,
Yeah, good.
a lung abscess,
Okay.
infection, tuberculosis.
Means pneumonia means maybe due to bacterial or viral or maybe due to tuberculosis. So with this hemoptysis, purulent sputum, you are more in favor of a bacterial and tubercular etiology of pneumonia, right?
Yes, sir.
Okay. Then abscess, you already said, okay. Or maybe some other problem like aspergilloma in the cavity after an effect of previous tuberculosis. This is also possible. Okay. These are the
Yes.
common in our settings. And
Okay,
pleural
sir.
also, with your history, we have pleuritic pain. Most commonly, we will get in pleural effusion or in pneumothorax, right? So
Yes, sir.
pneumothorax will have a catching type of pain and dyspnea. That will be the predominant symptom. It may not be having other symptom, but in pleural effusion, depending on the effusion type, whether this is a pure pleural effusion due to the pleural pathology, or if it is a bronchial or alveolar problem like a pneumonia with parapneumonic effusion, there may be associated cough, sputum, expectoration, and then a patient can develop a pleuritic pain. So these are the two probabilities. Okay. The vascular diseases we will be looking at the mainly are vasculitis and pulmonary embolism, and musculoskeletal always costochondritis and other rib fracture related pain and all these things. So very unlikely there is a vascular problem. The history is very acute, 2 week history and gradually progressing. Okay. Now we can move looking at the airway disease and the parenchymal disease and the pleural and a combination of all these. We will be looking at the other history and other clinical findings. Okay.
So can I move to past medical history?
Yeah.
So this boy has a similar illness for the past 8 years. He has expectoration of moderate to copious amount of sputum on most of the days. He has mucous sputum most of the days, sometimes turning to mucopurulent and greenish, and with occasional streaky hemoptysis. His father has noticed a bad odor in his closed room during morning hours, and he gets this exacerbation of expectoration with an episode of fever once in a month. So he also has a poor weight gain for the past 8 years. Then natal and postnatal history. He was a term-born baby of non-consanguineous marriage, born out of a lower section cesarean section. His birth weight was 3.5 kilogram. His mother does not give any history of resuscitation, NICU admission, childhood pneumonia, tuberculosis, seizure, or measles. Coming to the past treatment history, he has history of hospital admission for the similar symptoms for 2 times in the past. He got administered IV antibiotics and taken nebulized antibiotics in the past. And there was history of 1 episode of COVID infection 1 year ago. He was in home isolation. There was no history of breathing difficulty or desaturation noted. Coming to family history, he has an elder sibling. There was no similar history in the family. No history of tuberculosis, renal, liver, or congenital heart disease in the family. So personal history, he takes a mixed diet. His sleep is normal, appetite is normal, has poor weight gain. Weight is 48 kilogram and height is 173 centimeter. He has a sedentary lifestyle, a normal bowel and bladder habits. His socioeconomic status, father is a retired agricultural officer, mother is a housewife, and brother works in a private firm. They live their own house and safe drinking water and good sanitation facilities. According to modified Kuppuswamy scale, they belong to an upper middle class family.
Okay. So please summarize. Okay, you have something.
So here's a
Hello, Dr. Nilima, your voice not audible.
Am I audible now, sir?
Now audible. Please
Oh.
go ahead.
So to summarize, there's a 16-year-old boy with a chronic productive cough presented with exacerbation of the same, pleuritic chest pain, and fever of 2 weeks duration. He also has
Okay.
history of poor weight gain for the past 8 years.
Okay. So there is a lot of important information is coming from the past history. Can you please go back to your past history? So the boy is symptomatic from age of 8 years. Okay. So there is cough and moderate amount of sputum, and that is also purulent and also foul smelling many times. That was the
Yes, sir.
history given by the parents. So can you just elaborate when will you say acute cough, when will you say chronic cough, and what are the important chronic cough in this age group, and what are the differential diagnosis for the chronic cough?
Acute cough is when duration is more than 3 weeks. Subacute is
Less
when
than
it
3
is
weeks.
less than 3 weeks, and subacute is in
Okay,
between 3 to 8 weeks, and chronic cough is when more than 8 weeks.
good. Okay.
So
So this is the criteria. All of you remember, just remember, more than 8 weeks is the cutoff for chronic cough. Okay. So what are the important differential diagnosis in young or adult patient for chronic cough?
chronic cough, it may be due to cough variant asthma
Good,
and maybe a foreign body.
good. Okay.
And then post-nasal drip, upper respiratory
Yeah.
cough syndrome.
Okay. Good, good. Then
And
so we have to divide the problem either in the upper respiratory tract, or whether it is in the lower respiratory tract, or whether it is due to the gastroesophageal reflux disease, gastroesophageal system related. The most common upper respiratory problem as a present as chronic cough is, as you said, post-nasal drip or upper airway cough syndrome due to chronic rhinosinusitis. Okay. And the important lower respiratory problems, the chronic cough usually present like these are asthma, there is cough variant asthma. Okay. Cough variant asthma or bronchiectasis also. Okay. And other problem like gastroesophageal reflux, not purely gastroesophageal reflux, laryngopharyngeal reflux disease. Okay. And so it also can, you can divide this into chronic cough with normal X-ray and chronic cough with abnormal X-ray. Okay.
Okay.
So the Harrison has described like that, whether you can divide the chronic cough into normal X-ray and abnormal X-ray. So all these upper airway cough syndrome or your asthma, your GRD or LPRD, or your things, the other one is chronic bronchitis also. All this will be having a normal X-ray. But there are other etiologies like you have bronchiectasis, you have foreign body, you have interstitial lung disease, or you have a bronchogenic carcinoma. All this can have a abnormal X-ray findings.
Okay.
So looking at the history, so which chronic cough do you think or our patient is having?
With this copious amount of sputum lasting for 8 years, with an exacerbations with the fever, it could be bronchiectasis.
Correct. So tell me if, the condition where you get purulent respiratory secretion. Copious purulent respiratory secretion is seen in which conditions?
Bronchiectasis, lung abscess.
Okay. So how will you differentiate these two things based on your history? Bronchiectasis, purulent copious secretion, and the lung abscess, purulent copious secretion.
Bronchiectasis, we have a very long duration of history
Okay.
with the exacerbations and waning, but
Okay.
lung abscess will be an acute onset. Will have
Okay.
a acute short course of history.
So there is a other important one is normally the bronchiectasis, the classical description is a tri-layer or tri-layer sputum. You will have a, when you collect the sputum in a jar or cup, you will have 3 layer, initial mucous or frothy layer, then a serous layer, and the lower one will be a purulent layer. Okay, so tri-layer sputum is a classical finding in bronchiectasis, and there will be a long course with each, and in between you will have acute exacerbation and antibiotic history and all other things. And as you said, abscess usually a acute problem, but there can be subacute presentation also, and the abscess will have very foul smelling putrid due to the necrotizing nature of the organism. There will be a lot of necrotizing pneumonia happening inside the parenchyma, and the abscess generate a lot of foul smelling putrid bad smell, and there will be classical postural drainage, that is the postural change of copy secretion, also classical for lung abscess, but even for bronchiectasis also you will get postural if it is a bronchiectasis. For example, one lobe is involved, like upper lobe is only involved in bronchiectasis, and also you will get postural drainage. But if you have multiple lobes are affected, like bilateral bronchiectasis, then postural drainage we may not get in one position. It will be in all positions. So lung classical copy with very foul smelling and subacute or acute presentation, and classical postural variation is described. And if you have a young patient with this much bronchiectasis, what are the important other etiologies you will be looking?
Should look for.
You have already asked about the neonatal and other family history also. What are the important findings in the past history of a patient with a copious purulent chronic cough?
Should look for any history of foreign body aspiration.
Okay.
Recurrent seizure, that is causing history of seizure causing recurrent aspiration.
Good.
Any history of infection, serious infection, for example, measles or previous pneumonia. Past history of tuberculosis causing post TB bronchiectasis.
Okay, so the bronchiectasis have multiple etiology. We'll come to that, but and seriously we will be looking at the past history of serious pneumonia, as you said, TB or whooping cough, pertussis, or the measles, or foreign body aspiration will leading to all these problems. So as you correctly mentioned, so family history, what are the illness you will be looking in the family history for a respiratory disorder? What are the disease which can spread in family?
History of tuberculosis, history of contact with the tuberculosis.
Okay. That is due to one person having a sputum positive TB, the other person can get an infection. But what I'm asking in the genetic, you have drawn a pedigree chart, right? So looking at the pedigree chart, what are the genetic disorder which you can see in the families, especially because we know a lot of genetic disorder from respiratory point of view. What are the genetic disorder which can happen? You can go to the family history, please.
Sir,
Tell me, what are the disease which you expect looking at the pedigree chart or looking at the family history?
genetically there could be some history of cystic fibrosis.
Because it has some relation with our case also, because you have copious purulent sputum, which is having a 8 years duration, and there is occasional acute exacerbation antibiotic intake also look more in favor of bronchiectasis condition. So, and you have a family history, you have pedigree chart. So, what are the condition where this can happen with the history?
In genetically inherited cystic fibrosis, Klinefelter syndrome. Then
So mainly you have to think about mucociliary disorders, something which affect the mucociliary system. So that is Kataga syndrome or AM syndrome. Okay. So in your family, in the past history, you should also ask about recurrent sinusitis, and also you have to look for the means since the 18-year-old, there is no marriage history, but the lack of child or azoospermia is also an important past history. So these two, ciliary dyskinesia, and as you already mentioned, cystic fibrosis can is autosomal recessive disorder, but it can happen. Then alpha-1 antitrypsin deficiency. Okay, that also present like similar alpha-1 antitrypsin, cystic fibrosis, and Katagas and Young syndrome. And there are some in the congenital and form of interstitial lung disease also, and that is a rare and doesn't present like this. Okay, and other one are also congenital cyanotic heart disease. It is that presenting as secondary pulmonary hypertension and all these things, but that will not be this scenario. But our scenario, you have to think about alpha-1 antitrypsin, cystic fibrosis, and ciliary dyskinesia. Okay, please go ahead.
Okay. So from this provisional diagnosis, bronchiectasis with the acute infective exacerbation.
Okay.
So coming to the general examination, examined in well-lit room with adequate exposure, conscious and oriented cooperative, comfortably sitting. Boy has a very lean body habitus, moderately built and poorly nourished. Weight is 48 kilogram, height was 173 centimeter, BMI 16, underweight. There was no pallor, icterus, cyanosis, generalized lymphadenopathy, pedal edema, painless clubbing noted in all fingers, grade 4 clubbing, drumstick appearance of the fingers. Has a Marfanoid habitus, arachnodactyly, thumb sign and wrist sign was positive. Vitals, pulse rate was 78 per minute, regular in rhythm, normal in volume and character, no vessel wall thickening, no radioradial or radiofemoral delay. BP was 110/80 millimeters of mercury, measured in right upper arm sitting position. Respiratory rate 20 per minute, regular in rhythm, abdominothoracic, afebrile, saturation 97% in room air. So shall I proceed?
Okay, so what are the positive finding in general examination? You said clubbing, then underweight, then anything else?
Marfanoid habitus, arachnodactyly.
Okay, okay. So you said painless clubbing and grade 4. What do you mean by grade 4? Can you please describe?
So there will be drumstick appearance of the fingers.
So that is not, some books say like that, but classical grade 4 is clubbing with tenderness over the wrist and elbow. It is called
Hypertrophic
hypertrophy osteoarthritis. That is the grade 4. The drumstick appearance is grade 3. Okay, so that's a small correction from my side, I think. Second thing, can you go back to the other findings? Where you will be mentioning the vitals? It's coming. Okay. Okay, vitals are. So the respiratory rate and saturation. Okay, you're coming to that.
Is
Okay.
20, was saturation 97%.
Okay. Okay, we'll come to your findings. Okay, you proceed because of the time.
So systemic examination, upper respiratory tract examination. There is deviated nasal septum to the right, no visible polyps, no sinus tenderness. Oral cavity, there's crowding of teeth, dental caries were present, then high arched palate, tonsils and posterior pharyngeal wall normal. On examination of the chest, inspection, chest wall is symmetrical with the pectus excavatum deformity, trachea appears to be central, apex beat is visible epigastric and supraclavicular pulsation, there was no kyphoscoliosis, and there is reduced chest movements on inspection on apical, anteroposterior, and lateral chest wall. Palpation, trachea appears to be trachea is central, no local rise in temperature, tenderness, crowding of ribs, kyphoscoliosis or spinal tenderness. Apex beat is localized in left fourth intercostal space on mid-clavicular line. In respiratory movement on palpation, reduced chest movements on apical, anteroposterior, and lateral on right side, and normal movements on left side. Chest dimension, anteroposterior diameter was 20 centimeter, transverse diameter 31 centimeter. Anteroposterior transverse ratio is 0.6:1. Chest circumference on expiration 74 centimeter, inspiration 76 centimeter. So chest expansion was measured with 2 centimeter. Spinoscapular distance 9 centimeter bilaterally. On palpation, tactile vocal fremitus was reduced on mammary, axillary, infraaxillary areas on right side and posteriorly on interscapular and infrascapular area. Left side was normal. On percussion, stony dull note elicited on mammary, axillary, infraaxillary area and posteriorly interscapular and infrascapular area on right side, and left side resonant note is elicited. Upper border of dullness was percussed over fourth intercostal space and was not moving with respiration. Now, auscultation, vesicular breath sounds auscultated over the left side, and breath sounds was absent on mammary, axillary, and infraaxillary area, and interscapular and infrascapular area, and there was no added sounds. Vocal resonance, normal vocal resonance on left side, and absent vocal resonance on mammary, axillary, infraaxillary area on right side. Posteriorly, absent on interscapular and infrascapular area. Other system, cardiovascular system, S1 and S2 were normal. There was no murmurs. Soft and non-tender abdomen. High mental function was within normal limit, and there was no focal neurological deficits. To summarize, 16-year-old boy with a history of chronic cough and expectoration, presented with exacerbation of the same, pleuritic chest pain and fever for 2 weeks duration. On examination, he is poorly nourished, clubbing of fingers was present, Marfanoid habitus and pectus excavatum deformity. He has reduced chest movements on right side, and examination features suggested right-sided pleural effusion.
Okay.
So, provisional diagnosis, bronchiectasis with acute infective exacerbation, secondary pneumonia, right lower lobe involvement with associated parapneumonic effusion. No corpulmonale, not in respiratory failure, Marfanoid habitus.
Okay. So you have features suggestive, history features suggestive of acute exacerbation of bronchiectasis, but your clinical findings are more in favor of a pleural effusion, right?
Effusion. Okay.
Yeah. So your summary, you can say there is a features of acute exacerbation based on the previous findings, and your summary, not the other one, the diagnosis provisional. Okay. But with what finding we will be able to say there is a pneumonia? Is there any clinical findings which is favoring pneumonia with our clinical or science or history? Only thing is fever, cough, purulent sputum. That is the only thing which we have positive,
Yes.
right? In
Yes.
anything else, because we have a effusion finding with all the classical signs of effusion. Because in inspection you have reduced movements on the affected side, and percussion you have dullness, stony dullness on the affected side, and auscultation also you have a reduced or absent breath sound in the affected side, and vocal resonance and tactile resonance, all these tactile parameters, all these are reduced in the affected side. This is favoring of effusion, right? So right now you can say probability of acute exacerbation of
Yes,
bronchiectasis
sir.
with right side effusion, a probable parapneumonic effusion, because
Effusion.
we don't have evidence at present with the clinical findings to say there is a pneumonia, because you have not elicited a bronchial breathing or any other classical signs of tubular breathing. All these things are absent
Okay.
because of the effusion, probably. Okay.
Okay. Okay.
So what are the important differential diagnosis for clubbing, and what are the important respiratory condition which can present as a clubbing?
Clubbing is seen in lung abscess, bronchiectasis,
Okay.
then
Okay.
bronchogenic carcinoma,
Okay. And interstitial lung disease
lung
like
disease.
IPF, idiopathic pulmonary fibrosis. Okay.
Mm.
Okay, these are the respiratory thing. What are the other non-respiratory condition where you get clubbing?
Could be seen infective endocarditis,
From cardiology point of view, infective endocarditis, then
congenital heart disease,
cyanotic congenital heart
congestive
disease.
heart disease.
Okay, that is only present in cyanotic heart disease. Okay, then
Okay.
from other
Gastrointestinal
system
system,
like GI, yeah,
Crohn's disease,
inflammatory bowel disease, both Crohn's
bowel
and in
disease.
IBD, and cirrhosis. Okay, cirrhosis
Okay.
also. So now we have reached your provisional diagnosis. How will you proceed? What are the important investigation you will be doing?
First we should do
So your
blood
patient is hemodynamically stable, right? Your patient is
yeah.
also not in respiratory failure. You have mentioned that. Okay.
Yes,
So
sir.
that is also important finding. If the patient coming into emergency with tachypnea, hypoxia, then you have to stabilize initially patient by giving oxygen support and other immediate support. So now your patient is not in respiratory failure. So how will you approach? What are the important
Uh,
investigation you will be doing? And
so blood investigation, blood routine examination,
hmm,
then CRP, RFT,
okay,
LFT, then chest X-ray. So
okay,
long stay, 2 weeks history of fever. We can do a blood culture. Then sputum
okay,
examination, sputum gram stain, culture,
okay,
history of 2 weeks cough. So AFB and gene expert,
okay,
MTB gene expert.
good. So we can go to the chest X-ray now. Okay, can you describe the chest X-ray, please?
Chest X-ray showing right side homogeneous opacity, obliterating the right costophrenic and cost diaphragmatic angle, with the parenchyma showing air bronchogram and with cystic
Okay,
shadowing bilateral,
bilateral.
and there
Hmm.
is also scoliosis seen in the
These
spine.
are the positive findings. So if the examiner asks, this is a chest X-ray peer view of this patient, peer view, and all these findings you have to mention, and no other soft tissue or rib shadows also you have to mention. And pericardium and the cardiac shadow looks normal. And the musculoskeletal point of view, you have a minimal scoliosis because there is a spine bending towards right. Okay.
Okay.
So looking at the X-ray, you think there is a fusion. Definitely, our clinical finding is correlating. There is a fusion, and the underlying lung parenchyma, especially in the left and the right, left lower zone. X-ray we will say zones. upper, mid, and lower zones. The zone in the left or lower zone is also showing dilated bronchus. You can see some dilatation and cystic changes, right? And the right side also underlying effusion, there is a dilated and cystic bronchi, and there is you can keep the mouse near the air bronchogram. Can you show the air bronchogram? No, coming lower side, in the water, you can see this one. Yeah, correct. So these are the air bronchogram. Okay. So now you can say there is acute exacerbation of bronchiectasis, probably a pneumonia with parapneumonic effusion, right? So what are the different etiology for a bronchiectasis? Tell me what is bronchiectasis and what are the differential diagnosis or what are the causes for bronchiectasis?
Bronchiectasis is the irreversible damage to the airway that is caused by
It is
the
permanent destruction and dilatation of the bronchus due to infection and inflammation, right?
inflammation.
Chronic. So there is a destruction is there is a dilatation is there, and it's a permanent problem. Okay. So what are the causes? Please go ahead.
So it could be infective cause or non-infective cause, or based on,
Okay.
it could be a focal and diffuse involvement. Focal,
Okay.
it is obstruction due to foreign body, tumor or mass obstructing. Diffuse involvement, it is due to
Foreign
autoimmune
body, tumor, and one more thing I would like to emphasize is compression from the external,
mass.
like mass externally or lymph node externally or a vascular aneurysm externally. Okay.
Okay.
Hmm.
Then diffuse involvement, it could be due to autoimmune conditions like rheumatoid arthritis, Sjogren's syndrome, and genetic conditions, cystic fibrosis, Klinefelter's, alpha-1 antitrypsin deficiency, and allergic bronchopulmonary aspergillosis.
Very good. ABPA. Okay. So, can you tell me a few conditions where upper lobe bronchiectasis is seen? Can you see or central bronchiectasis versus peripheral bronchiectasis? Any such idea? What is your idea about any upper lobe bronchiectasis? Few conditions where you will get upper lobe predominantly affected.
Post tuberculous bronchiectasis, upper lobe.
Good. Post TB, post radiation, and cystic fibrosis also predominantly has been seen affecting the upper lobes. Okay. Okay, fine. Then what else? What is central bronchiectasis cause of central where the major central airways are affected? Can you tell an important cause for central bronchiectasis? Important cause for central bronchiectasis is ABPA, allergic bronchopulmonary aspergillosis. Okay. Okay. So what you will be doing is you also have to do sputum examination. So and the routine blood investigations, right?
Okay.
So what are the routine investigation findings? Show anything positive you can see in the routine blood test or CBC, RFT, LFT, or ESR or any other collaborative findings? Yeah. So very high total count.
29,000 total count. ESR was 90, CRP was 475.
Very high. Yeah, good. LFT, RFT normal.
Normal.
We can also see anemia as a bout of chronic infection because it's a chronic problem. Anemia of chronic disease can be seen in the CBC finding, okay, which is not present here. And albumin will be low, like hypoalbuminemia also find as a part of chronic infections. Okay, sputum gram stain culture. Okay, go ahead.
Sputum gram stain showed moderate gram-positive cocaine pairs and short chains. AFB smear, no acid-fast bacilli demonstrated. And Mycobacterium tuberculosis gene exported not detected. And sputum culture and sensitivity showed moderate growth of Pseudomonas.
Okay. So, and your history also collaborating with Pseudomonas growth. You also said greenish sputum, right?
Yes.
So, what are the color wise? You have any clue from the history? What are the different color of the sputum which affect the diagnosis? Can you please remember any color like green for Pseudomonas? Anything else?
Klebsiella showed red currant jelly sputum.
Okay. Pneumococcus. blood stained, streaky
rusty
blood,
sputum.
rusty red.
Sputum.
And what about congestive cardiac failure? Pink frothy sputum.
Pink frothy sputum.
Okay, pulmonary edema. Okay, then how will you manage? We'll come very quickly into the management. We'll have it. After that, we'll take a few questions. Okay.
Okay, first, start on supportive medications like management of pleuritic pain, nebulization, and empirically start on intravenous antibiotics. And for the it's important part is drainage
which
of
are the antibiotic? Okay, so first important thing is you have to give the analgesic like antibiotics for the fever. Second, IV antibiotic, as you said, and third one will be the postural drainage. And looking at the X-ray, we are thinking it's a parapneumonic effusion, but a clinical assessment by a bedside ultrasound also has to be done, looking at the volume of the pleural effusion and any septations, or we can also do a diagnostic pleural tapping also to confirm whether it is parapneumonic or is there any complicated parapneumonic effusion or an empyema present or not. Okay. So you don't have tenderness while percussion, right?
Sir?
You haven't felt any tenderness while percussion. So very unlikely there is an empyema. Empyema necessitance or empyema unlikely. So we will go with the finding that this is a parapneumonic effusion. So IV antibiotic, with an IV antibiotic, you will be preferring for Pseudomonas growth. Can you tell me a few IV antibiotics for, which can be given for Pseudomonas coverage, for cephalosporin and other groups of antibiotic where having a Pseudomonas coverage, and which is the drug you prefer?
Aminoglycosides.
Okay.
Quinolones.
Aminoglycoside is having Pseudomonas coverage. That is correct. Then quinolones is also having Pseudomonas coverage, but especially for ciprofloxacin. Okay. But these are not the important drugs. We will be giving most importantly either a beta-lactam or a beta-lactam plus beta-lactamase combination. So what are the, among beta-lactam, tell me what are the anti-pseudomonal beta-lactams? Or among cephalosporin, what are the anti-beta-lactam or beta-lactam, sorry, anti-pseudomonal cephalosporin?
Ceftazidime.
So cefoperazone and ceftazidime. Okay. So you can give cefoperazone or ceftazidime. Usually cefoperazone comes as plain also, or it comes as a combination with the sulbactam also. So then it will become BL-BLI, beta-lactam, beta-lactamase combination. Then from the other one is piperazidine tazobactam is having a very good pseudomonal coverage. From carbapenems, both meropenem and imipenem is having very good anti-pseudomonal coverage. And aminoglycoside is also having a very good, but fluoroquinolone we generally don't use because of the rapid resistance and the tuberculosis prevalence in India. Fluoroquinolone doesn't be or never should not be used as a first line drugs. Okay.
Okay.
So with this history and the management point of view, what you think in this case as a etiology? Because we already said a lot of etiology. We have to also work up for the etiology also, right? Like you said, connective tissue disorder. You said cystic fibrosis. You said various other causes. So out of this, for this young patient, what do you think the etiology probability? Post-infective. So post-infective is one, means any previous severe pneumonia. Unlikely because you are not giving any severe pneumonia in the past. And second, also this is not a focal, because if it's a post-infective, this will be a focal corresponding to that lobe of the. This is a diffuse one. You have CT scan for you. Can you show me the CT scan? Yeah. Okay. Any other cuts? Here you can see there is bilateral extensive bronchiectasis. Both sides are affected, right?
Yes.
So go back to the previous image. Here also you can see bilateral. So it's a diffuse problem. So out of the diffuse problems, what do you think the probable etiologies in a
Could be
young
some
patient?
genetic causes should be
Genetic
ruled out.
points. Okay, so both ciliary dyskinesia, cystic fibrosis, alpha-1 antitrypsin, all this has to be ruled out.
Okay.
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 So what else? In the management, postural drainage, very important. You have to advise the patient for postural drainage and also mucolytics. You have to give good amount of mucolytics. Mucolytics in the form of N-acetylcysteine or a 3% saline or a 7% saline nebulization, because hypertonic saline is always take more amount of water from surroundings to the respiratory secretion. It will help us to reduce the thickness. And there is nebulized medications also, nebulized hypertonic saline, nebulized N-acetylcysteine, and oral N-acetylcysteine also helpful for the drainage of secretion. Okay, for long-term management, what are the treatment plan? For long-term, if somehow patient has improved. So this and the follow-up, what can be the management in this episode? We have to give, how many days of antibiotic we'll be giving for this patient? Any idea?
14 days.
Because it's a pseudomonas growth. Pseudomonas is a gram-negative bacteria, very difficult to eradicate from the lung. So once you have an acute exacerbation with pseudomonas, you have to give 14 days IV antibiotic, and you have to repeat a culture. If the culture is showing again a pseudomonas, and a pseudomonas eradication program like inhaled anti-pseudomonal drugs like colistin tobramycin plus an oral drug like quinolones has to be given if there is a repeat course of or the patient. So it's just this patient definitely need a pseudomonas eradication also. So you have to repeat the culture after 14 days, and 14 days of IV antibiotic has to be given. What else? Because your patient is also having extensive bronchiectasis, this patient also has to get a pulmonary function test after the acute exacerbation to look for the obstructive or the lung function, and whether he need long-term bronchodilators or not. And also you have to give vaccination for him to prevent further exacerbation. Vaccination for influenza and pneumococcal vaccination also very important.
Okay, sir.
Okay, so we'll stop here and we can take some question. Any questions from the audience can be welcome, or any comments, please. Any question in the chat box? If there are any doubts, questions. So what are the radiological bronchiectasis? Meanwhile, we'll just finish the CT signs of bronchiectasis.
Sir, this
Type of bronchiectasis, we have cystic bronchiectasis. We have 3-4 types. Cystic is one type. Okay. Tubular is another type, and varicose. These are the most important types. Cystic, you will have a lot of cystic spaces. Tubular, you have dilated tubular bronchus. So, what are the important other radiological signs? You have any idea?
Tram track appearance and signet ring appearance.
Okay. So here you can see signet rings. Yeah. Ring appearance, thickened bronchus. Okay. Tram track is also another signs of thickened dilated bronchus. And one more, early bronchiectasis, you will have a ratio bronchus, the ratio 0.5 vascular ratio, and lack of peripheral pruning. This is also an important thing. Dilatation, and as you said, ring sign, tram track sign, ratio of bronchus to vessel sign, and the appearances, cystic, varicose, tubular appearances. Very rarely you can also see fungal growth in the cystic space, like aspergilloma, where you can get air crescent sign, And sometimes during acute exacerbation, you can also see air fluid level in the cystic space, suggestive of active infection and secretion inside.
Okay.
So which mutation you will be looking in for cystic fibrosis?
CFTR gene mutation.
Yeah, delta F. CFTR gene mutation. Most common is delta F508 mutation. Alpha-1 antitrypsin is a blood test. You have to look for the level of alpha-1 antitrypsin. Most commonly, it affects the skin and the liver also. Okay. Then there will be positive family history also. Ciliary dyskinesia, ideally you have to do a endobronchial mucosal biopsy and to look for under electron microscopy to assess the ciliary function. That's how it has to be confirmed. And there will be widespread bilateral and other associated sinusitis and azoospermia will also be there usually. And anything else? Nobody is asking question, I think. Any question, please ask.
Sir, which is the gold standard test for looking for tuberculosis?
Textbook for tuberculosis.
Yeah.
Textbook, okay. We
No,
have
gold standard test. I am lab.
test for gold standard is always mycobacteria from this. That is a gold standard because that is having maximum sensitivity, maximum specificity. That is a gold standard test. But in general, now we have moved for the rapid diagnostic tests like molecular tests, both PCR based molecular or nucleic acid amplification based tests. The GeneXpert is one of the tests where we'll be looking both presence of tuberculosis and also rifampicin sensitivity also. And GeneXpert is there, GeneXpert Ultra is there. So these are rapid and fast. It means you will get the result within 1 day, and you will also get an idea about whether rifampicin sensitive or not. So now we always send culture, but that is the gold standard. But our main idea is we will be more nowadays. We will be more using molecular tests like GeneXpert or PCR based test.
So, sir, in this patient, ESR was 90, no, sir? So, so was the pleural fluid study done?
Okay, so good question. ESR very high, around 90 to 100 is a sign of tuberculosis. ESR is non-specific marker. More than 100 ESR is seen classically in tuberculosis, multiple myeloma, and also our this one vasculitis, that is temporal vasculitis, temporal arthritis also. So these are the three things. And out of this, our patient doesn't need a pleural fluid analysis. We thought it is parapneumonic, and after sufficient antibiotic, patient has improvement. Nilima, can you show the follow-up X-ray, please? This is X-ray at discharge. Anything? One more X-ray is there? No.
One
follow-up OPD.
No, sir. This is the last X-ray.
This is the last X-ray. So there is significant improvement with the antibiotic itself. So pleural fluid aspiration study is not done.
Okay, sir.
For the completion's sake, you can do. There is no problem in doing that. But it was not done for this patient, and there is a good evidence of improvement. The effusion has reduced, and lung is also expanded from the side.
Okay, thank you, sir.
Please explain postural drainage, role of quantiferon TB test in diagnosing TB. So postural drainage, we have different positions for postural drainage. So you have upper lobe, middle lobe, lower lobe based drainage point of view. So looking at the X-ray or CT, you have to decide which lobe is affected, whether upper lobe is affected, middle lobe is affected, lower lobe is affected. So upper lobe drainage position usually will be, that is also depend on the segments we have to position. Middle lobe and lower lobe, usually we need a separate positions. So lower lobe, coming back to the lower lobe position, usually lower lobes are drained when your leg portion is raised and in the lateral position, either right or left, right lateral or left lateral, and head portion down, and the leg part will be raised. And middle lobe, right and left, the right side middle lobe and left lingula also need special positions. And upper lobe also have both in sitting position, also good for upper lobe, and also in lying down position also good for means the prone position also good for upper lobe, especially superior segments. So we have a chart for that, which segment you can select, can available in the internet. Or looking at the chart, we will be deciding which segment and what are the position. Second question is asked regarding interferon, role of interferon or IGRA, that in diagnosis for the tuberculosis. So we can never diagnose TB based on TB Gold or IGRA. IGRA is interferon gamma release assay, otherwise called TB Gold test. It is one of the tests to diagnose latent TB. Latent TB means you have taken the TB bacilli into your body, and your body has generated sufficient immune response against the TB bacteria. That is the only evidence where TB Gold can say that you have sensitized with the TB bacteria. That doesn't mean that you have active TB. Active TB is based on the other clinical symptoms, radiological signs, and the pathological and the microbiological evidence is also required. So TB Gold usually nowadays done for looking at the latent TB, and you can also use Mando test also for the same purpose. But Mando test can be affected by two problems. One is previous BCG vaccination. Second is previous, especially previous BCG, and also non-tubercular mycobacteria. We have a lot of non-tubercular mycobacteria in and around. So these bacteria will also give Mando positivity. So to avoid these interference, TB Gold is better, and it cannot be used as a diagnostic test for TB. It is a test for latent TB or inactive, or you have not developed the active clinical tuberculosis. You have developed a immune reaction or sensitized for the tuberculosis. Patient had scoliosis. Yeah, we have discussed that during the X-ray. There is scoliosis towards right side. Yeah, you are correct. We have also discussed during the X-ray. Scoliosis is correct. So because of scoliosis, because of the chronic infection, patient is malnourished. He also has to look for the calcium and vitamin D also, this patient. And if there is deficiency, that will also be that has to also be corrected. Dr. Neelima, if you have the internet connection with you, you can take that postural drainage photograph from Google and show to the audience if you can. Just type postural drainage there, and you will get in the web page. You will have a chart of different segments. Yeah. Can you make it bigger? This one, the red, can you take the red one? A picture with the red patient. Yeah, correct. This one, red one. Yeah, that is more visual. The audience can see better. So you can see right posterior segment of the upper lobe where you need supine position and a little bit lateral. If it is right side, you have to keep the right side up. In left posterior segment of the upper lobe, this is the little bit 45-degree angle and the left side up. And right middle lobe, you can see head has to be little bit down. Since it is right side, the right chest has to be in the upper position. In the left lingula, that is the left side corresponding to the middle lobe, patient head should be down, and the affected part, that left side should be in the upper position, so that we can percuss there and drain the secretion. Sufficient lateral segment of the lower lobe also, you can see head has to be down and the affected part, right side, if it is right side should be up. So, and this is the, and you have, you can also give a prone position for also for the lower lobe. So these are the way we usually do postural drainage. Before postural drainage, we will be giving a good amount of nebulization and also mucolytic nebulization, both the hypertonic saline or bronchodilator before attempting postural drainage. And we have a new device called Acapella. It is also a help in postural drainage. It's a vibrating chest device. You can search in the Google and show the others. Acapella is there. It is available now in Indian market also.
So may I know the spelling?
Okay. Acapella. Why Acapella? Just one device. Just you have to type just vibrating device. Then you will get it. Okay. That one. Patient has to forcefully blow. There is a special type of breathing. There's a positive expiratory valve is there that will give a positive expiratory pressure. With that positive pressure during exhalation, there is a vibration effect will come into the airway. It's otherwise called PEP device, PEP, positive expiratory pressure device. Okay, this will also help for the patient to do for a better postural drainage. This is available in our market also, PEP device. Okay, thank you. Any other question? We'll wind up the session. Thank you all for joining. And I hope I have discussed the case within a very short notice. Thank you.
Thank you so much, sir. It was a very informative session. Thank you, Dr. Nilima, for presenting the case so well. I call upon Dr. Nikesh to deliver the vote of thanks.
Very good evening to my all. So we have concluded the monthly academic section for the November, which is organized by the FPI. So I think as a family physician, as a practicing physician, one of the most common complaints that most of the complaints that the patients will be presenting will be pertaining to respiratory system. So I think this session has been very helpful to all the residents and all those who have participated. So am I audible?
Yes, Nikesh. There is some connection problem, not so audible, but in between your sound is getting some.
I think there is some issue. So So first of all, I would like to extend our gratitude to our moderator, Dr. Mujibur Rahman, who is a consultant in the Department of Pulmonology and Critical Care, BPS Lakeshore Hospital, Kochi, to take out his time from his busy schedule. And he is a very busy practitioner. And this was actually very short notice to him, but still he has guided us through the case presentation in a very great and very simple and very understanding manner. And so we understood that he is having very immense knowledge in his field, and he is guided very well. And the way he explained the topic was also very exemplary. And I am more happy today because we have I had the pleasure to study with him together for during our MBBS undergraduate entrance examination preparation. So I thank you, Dr. Mujib. So you have moderated the session very well, and those words has been very grateful to all the residents, those who have participated. And I also thank our presenter, Dr. Neelima, and she has taken the case very very detailed manner and very helpful manner to all the residents. And thank you, Dr. Neelima. Organizing team from the Spice Route, and also and from the AFPI, those who have helped in organizing this session, especially Mamta and Dr. The Anuna Vinod. And also I thank our mentors. I also thank the whole of the participants who has taken time to, we have participants from all over India. And I will thank all the participants, those who have joined in our session. And okay, so once again, I thank you all for your